we're recording this so folks can go back and listen to it, and you can share it. We're going to put a copy of it on our website. So if you want to share it with other people, it'll be there, accessible on our website. So then we also have a newsletter that you might want to sign up for, where we try to push out meaningful content, when we get it. You can find the sign up for that on our website, which is directmedclinic.com. And again, this is being recorded. Your microphone's muted. If you want to ask a question, you'll have to unmute yourself. And there is a chat group going, so if you want to ask a question but don't want to come on the microphone and ask it, you can type it in, and I'll try to notice it that way. So now let me get back to where I am and what we're doing here. I'm Dr. Roger with Direct Med Clinic, and we're independent. We're not part of a big health group or some big clinic chain. And that's a good fit for me, because I like being able to be independent, so I can have a relationship with my clients, like employer clients, and then also patients. So for a clinician, it's a good feeling to be sitting in a room and know that you can do what's right for the patient, because you don't have insurance worrying about, or you don't have to worry about the insurance, whether it's going to be authorized and all of that stuff. And so anyway, we're trying to do the best thing for employers and our individual patients. So with that being said, you know that you might hear something different on the CDC than you hear from me. You might hear something different from Metro Health that you might hear from me. But again, my position is to try to take all of that information that's clinical and reformulate it into something that is understandable, palpable, and applicable to an individual patient, or in this venue here, for an employer. So with that, kind of the format of this meeting is I will ask if anybody has any questions, and we can talk about that. And then if we don't have any questions, I've got a fallback plan. I was going to talk about return to work. So let me just pause for a minute and see if anybody has a question that you want to ask right off the bat. You can always ask them later. I don't see any questions in the chat box.
I have a few questions, Doc, but I have a feeling that you're going to cover some of them in the return to work section. So I'll just go ahead and wait and see if you're covering. I don't want to get you out of sequence. Okay. Okay,
perfect. Yeah. So we are accepting questions before the meeting, and we've got a few, and a lot of them do have to do with return to work. And so as I go through this this little diagram that I've made up, I'm sure that it'll answer a lot of questions, or I hope it will. And the reason that I wanted to talk about return to work is because I know that it's on the mind of employers. We had an issue with one of our employer clients this last week, where he has a small company. He had a couple of people out sick, and when they were ready to return to work, they reached out to him and they said, "Hey boss, okay, we're ready to come back." Well, he wants them back, of course, and he's got a job to do, but he's really kind of worried, like, are they ready to come back? Do they need some kind of a test, or do they need to see a doctor? Am I going to get what they had? If they had COVID, are they going to spread it to me? Or if they're out on the job site, are they going to be spreading it to other people? And so those kind of questions were in his mind. And so with that, I'm trying to hold myself out and say, let's talk about this, okay? From a clinical standpoint, what you can do, and we can talk about what he did. So to get started, let me go ahead and share my screen and show you what I have prepared for y'all. So here, here is what I put together to try to make some sense out of the return to work issues. Okay. So here you've got a sick employee. So let's say that there's a non-respiratory illness that they have. So over here in this box, they stay home till they feel better. Okay, I don't think anybody is too worried about those kind of things. You know, they've got, you know, a sprained ankle, they've got the sniffles or something like that. Okay, so over here it starts to get a little more worrisome if they've got a respiratory complaint, because obviously COVID is a respiratory illness. So with that, the recommendation for them is to stay home for 7 days and come back to work when they are feeling better, they're not having a fever, without having to take Tylenol or ibuprofen. Okay. Now, and we could classify this as maybe an upper respiratory infection. So now it gets a little more suspect here with someone that is sick and they have what they call the lower respiratory symptoms of shortness of breath, fever, cough. So we'll call this category a suspected COVID infection. So if we are suspecting that they have COVID, we're going to have them stay home for 7 days. Okay? Then after the 7 days, there's a way to let them come back to work if they're feeling better. So there's 3 criteria here: feeling better, and they're without fever for 72 hours, and not taking their Tylenol or ibuprofen for those 72 hours to control their fever. So they stay home for 7 days, and then their symptoms improve, and then they can come back to work after 72 hours of no fever when they meet those criteria. Okay, so that's with somebody that we are suspecting might have COVID. Any questions about that one? If so, feel free to chime in. We'll move over here to the next one. If someone is confirmed positive with COVID, they're gonna stay home for 7 days, treat their symptoms. Then under this box here, I put test method because I'm assuming that over here they tested positive with COVID. And there are 2 ways to send someone back to work after that. There's the non-test method, and then there's the test method. So actually I could have drawn an arrow from here to here, and it would still be applicable. So basically the non-test method is for a confirmed COVID is you stay home and self-treat for 7 days, and then your symptoms get better, and then you can have another PCR test, and hopefully it's going to be negative, and then you have another one 24 hours after that, and if it's negative, then you're going to be able to go back to work. Okay, now that PCR test is the one we're talking about. What we're doing is where these 2 tests come in this box here. Okay, and we talked about last week how the PCR test tests for active disease. So by doing the test method, you're looking to see that the virus is not detectable anymore in their body. And that's what the PCR test does. It's looking for a little piece of the virus, and that's a positive test. So if you want a little bit more detail and insight on how that test works compared to the antibody test, go look up the last webinar that we did last week. It's posted on our website. Then under here, I've got a recommendation that's out there to wear a mask for 3 days. Now, this is the person that's returning to work. So they come back to work, they wear a mask for 3 days, and they continue social distancing. They continue social distancing, and then they need to wear a mask when they are not able to maintain the social distancing. That's how I should say it, okay? Then over here, we've got someone that has had a confirmed exposure. So that person needs to stay home and isolate themselves for 14 days, okay? So you might be asking yourself, why is it 7 days over here and 14 days over here? That's because over here, these people are symptomatic. They're already sick. Over here, these people are not sick. So there's an incubation period that COVID has. It's about a week, or it could be up to 14 days. Actually, it could be up to 14 days, but mostly it happens within the first 5 or 7 days before they get symptomatic. Okay, so if you're a little confused about the 7 days or 14 days, hopefully that helps. Okay. So any questions on what I've presented here so far? Okay, I'm not seeing the chat box right now when I'm sharing my screen, so your question might have to hold there if you don't want to turn off your microphone. So I wanted to add a few more considerations to this diagram here. I listened to a podcast earlier this week that came from Johns Hopkins, which has a tremendous preventative health and public health program. And what really struck me about that is they had an interview with a guy who was in charge of containing the country of Liberia when they had the Ebola outbreak. So he had firsthand experience on getting control of an extremely serious disease, kind of like COVID, except more folks were dying with that one. And he brought to light some concerns that he felt like we weren't doing here in the United States. And he emphasized really 3 big things: contact isolation, testing, and let's see, contacts, isolation, and testing. Right, that's what they were. So that's why I put these other things up here. And that's why I feel pretty strongly about using the antibody test. And I put on here places where I thought that was important. So if you have somebody with a respiratory complaint, you could consider doing the antibody test on them because we know that half of the people that do test positive with COVID are asymptomatic or they don't have symptoms. So here they have respiratory symptoms. So it's a quick, easy, economical way to check for COVID in somebody that we don't have a high suspect for having the disease for, but we're trying to be hypervigilant and protect our own employees, protect our workforce, and our community. So that's just another way that we can apply some testing. Okay, then when we have somebody that does come up or that we are suspecting has COVID, this is somebody that has not had the expensive, long PCR test that we hear about in the media. We can consider antibody testing for them, okay, to maybe move them out of this category or move them here or move them here, just with our level of concern. That being said, this antibody test is not supposed to be talked about as a test for or against or negative, positive or negative for COVID, but it's something that we can consider in our decision making. But what is important here is isolating the contacts of these people. So like I said earlier, half the people that do test positive with COVID are spreading the disease, not even having symptoms, you know? So we don't hear a whole lot about that in the media, or I haven't, about isolating contacts. So these contacts need to be isolated for 14 days. So we're not letting this guy here who might have infected some of these folks go out and spread the disease. Okay, now something interesting to think about is, you know, with the incident on the cruise ship, or what's happened in a couple of nursing homes now, that is kind of like a pretty enclosed population. So they're able to contain everybody and then test everybody. And then from that testing, they can figure out who in that closed group has contacts that might be outside the group, okay, like in a nursing home. So for example, if somebody tests positive and they're asymptomatic in that venue, they need to see who they've been around outside that environment so they can reach out to them and contact them and say, look, I'm positive with this, or it's, you know, so we need to have you go isolate. So take that group of contacts, send them home in self-isolation for 14 days and see who comes up positive. Hopefully nobody does, but you see, it might take them a week or so before they do turn positive, okay? So by isolating contacts, can you see how we're preventing the spread through the community by doing that? And I don't think that we hear enough of that from the media channels, you know. So then here, of course, it's kind of a no-brainer. If we do have somebody that is confirmed positive, we need to definitely reach out to them and formally isolate their contacts, okay? And then up here, if somebody is sent to home isolation because they've been exposed to COVID, then that's another place we can consider using the antibody test. And that test will turn positive up to 3 days after someone starts to get COVID. So I hope that makes sense. Now, as an employer, you have a little bit of background as to what the recommendations are and what you're going to be seeing and when to isolate people and for how long to isolate them, whether you think you want to send them for an antibody test, or send them back to their doctor, or let them come back to work. So I hope that makes sense. That's kind of what I prepared. But before I open it up to questions, we did have another issue come up this week that is important as far as sharing results. So as a medical doctor, as a clinic, we cannot share any kind of diagnoses or medical conditions with employers. But obviously, this is a little different scenario now with COVID-19 because it affects employers, it affects our whole community. So the rules that govern that are called HIPAA. So what we found is that there is a clause that allows us to share this sensitive health information with employers. In order for that to happen, the employee has to sign a release that lets the clinician know that it's okay with me if you share the results of my test or my illness with the employer. So we have those for the employers that we're doing testing for. And if you are an employer and you need to have that form and give it to your employees to take to their doctor to to get a release of that information, just let us know and we can get that for you and you can give it to your employees. Okay, so are there any other questions?
Dr.
I have a
Roger?
question, Doc.
Okay.
Yes.
If an employee is asymptomatic and shows up for work, as a preventive measure, should we be doing antibody testing or something? And what frequency? Just because someone tests positive or negative or positive, or if they don't have the antibodies today, at what point, they could go home or on the way home contract the virus. So what is the frequency that we should be testing employees?
That's a good question. And I went into that in a lot of detail last week when I explained the antibody testing and I explained the science behind it. So to give you a short answer though, it's the antibody test will become positive about 3 days after somebody gets COVID. So if you test before that and they're negative, you might have had a false negative. But if you test after 3 days, that's when it'll become positive. And so from an employer standpoint, if you want to try to control or your workforce, try to keep operations going, you might consider testing everybody and then repeat testing everybody on a certain periodic basis. And we have employers that we're actually doing that for. So if you are interested in that, if you're an employer, let us know and we can chat more about it. Also, you can go back and look at that webinar from last week on our website.
Okay, thank you.
You bet.
Dr. Roger, I have a question for you.
Yeah. Hi, Tom.
So normally in a work-related incident, illness, or injury situation, the employer engages a clinic or a physician to review and assess the alleged injury or incident or illness. At that point, the physician then provides that employer with restrictions, diagnoses, recommendations. How would this incident, assuming that they claimed or the employee is claiming that it's work-related, the COVID infection, how would this differ from a normal employer, employee, and doctor relationship for a work-related injury? Is there any difference?
There is. So what you described as a work-related injury, well, like what I want to say is HIPAA doesn't apply to work-related injuries, and that's why a clinic or doctor can share that information with the employer, and that's why I brought up this release that if it's not a work-related injury, the employer still needs to know if they've got someone that might have COVID in their workforce, because they need to protect the rest of the workforce. So that's why it's important to have this release, and that's something that the employee signs and gives permission for the clinic to release the positive or negative test to the employer.
So you're assuming and speaking to the employee that comes in with a potential COVID issue that is not a work-related. What if the employee says he feels it is a work-related?
Okay, that's a good question. And like I've been doing for years, and as I teach my nurse practitioners to do when we're dealing with work comp injuries, whenever we have an initial injury, that it's up to the doctor or the clinician to document that initial visit really, really well, because what that does is down the road, if there's questions to whether if this is work related or not, they always look back to the initial doctor visit. And if the doctor is not thorough enough there, then it's, you know, it's going to be hard for that employee to claim that as a work-related injury. It just gives rise to disputes. So in this environment, if an employee came and said that, hey, I got COVID at work, you know, this is work-related, it just puts us on alert to delve a lot deeper into, well, why do you think it happened at work? Why do you think you were exposed? Was there someone else at work that is exposed, and all that? So we just have to document that it was, and then to a level that would prove to a clinician that it is or it is not, you know. So we need to, you know, the clinician just needs to be on alert and do a lot of good documentation.
So the reason I bring this up is because the workers' comp carriers are going to be looking to medical opinion or medical finding in the due diligence that the physician or clinicians are doing to help them determine whether it is a work-related injury or it's not. So I guess the question is, how deep are your people and yourself going to dig, or maybe dig is not the right word, but how thorough are you going to be in gathering your information to determine if there was exposure or not? Because ultimately, your information and your report is going to be used by the workers' comp carrier to determine whether it's a work-related injury or not. It'll be one of the methods.
Exactly right. And so that's why we have a template that we follow when we're suspecting someone with a COVID complaint. And, you know, I'm trained in this in workers' comp, and then, you know, my nurse practitioners know to document a lot more on an initial work comp injury. So we're on top of that, and I'm sensitive to that already. And I saw a notice just earlier this week that the Division of Workers' Comp has suspended all designated doctor exams for the time being. And it just made me think how hard of a job those designated doctors are going to have down the road when things start working like they used to, and they're going to have to be making those decisions of whether this case was or was not a work-related injury. It's going to be hard. So we're going to do our part best we can to document as thorough as we can to prevent those disputes from coming up, and to make it easier on the work comp carrier or the employer and the employee. You know, we always do the right thing for the employee, the person in the clinic, but we can't ever forget the documentation that we have to do behind that.
So what is the employer, what should the employer give you as far as information when they're sending an employee to you that will help you in your documentation?
Okay, well, if the employer has any information about any other positives in the workforce or potential exposures, that would be extremely helpful. Or to the contrary, you know, if the employer has other information that they can share, we're all ears. You know, we're not biased this way or that way to the employer or that kind of thing. But like I said earlier, we're first going to focus on the patient and then fill in with as much detailed, pertinent documentation as we can.
Okay.
Dr. Roger, I would think that, I think I mentioned this before, it's just like the flu. How can you pinpoint it down and make it specific to a work environment versus home or vice versa? Because we've seen how whole departments get sick with the flu, or everybody at home is sick with the flu, and both.
Right.
So I would think that that would be kind of difficult to pinpoint it as to whose fault it is or who's responsible for it.
Right. And I'm sure that the work comp carriers will probably be looking at case history, and maybe some flu cases will come into play when they make their high level decisions there, and what's going to come down. We'll see.
So I think just to share a couple of examples, I've got a client that had an employee working on a job site in Austin with a general contractor. That general contractor's management, one of the management team members, ended up with a positive result on that job. And that precipitated another employee that was working closely in the same office with that PM that belonged to my client, who was a sub on that job, to question some of his issues that he was having physically. He went and got treatment, got tested, and he ended up being positive for the COVID-19. Now, in that particular case, there was a direct link to a job-related exposure that caused this individual to have this issue. In that particular case, we could define that there was contact, there was a direct link, and in that situation, that's being treated as a work-related exposure. Now, if the situation had been different, is that where you make the call? Hey, there was exposure, or there was no exposure that we can see. We will treat this as a personal patient-doctor thing, or how do you write that up, I guess is what I'm asking.
Yeah, so if in that case, we would definitely document that there's an exposure through a co-worker, and then that would go a long way to tag this case as a work-related injury. But we will ask those questions in another case if you were exposed at work. And if there's a possibility there from the patient, then we'll continue to ask those kind of questions. But if there's not, if there's no exposure there, then we won't follow those questions, or ask more about that. So that's what we do. It's documentation.
Dr. Roger, what is considered being in contact with someone? I mean, when you look at the definition of have you been exposed, who's been your contact, how do you define that?
Well, that's I'm not sure there's a good answer to that question right now, because we like we know, folks can have contact with people that are asymptomatic, and we don't even know where they got it, but somewhere they got it, But what we're recommending to employers, as far as letting somebody go back at work and contact at work, is within 6 feet for more than about 10 minutes would constitute a contact. And we got that from the American College of Occupational and Environmental Medicine on a seminar we had last week with them. So that's within 6 feet for more than 10 minutes. That's contact in the workforce. And we all know that social distancing contact is just stay more than 6 feet away. Okay.
So if an employer is wanting to see how to set up, how to bring back on board employees, and they don't really have a plan, what would you suggest? How would an employer emerge from having very few employees at the work, or maybe not having any employees at work? How would they be able to bring them back to work safely to kind of mitigate any potential, hopefully, workman's comp issues and do it as safely as possible for the rest of the employers.
Okay.
I'm kind of thinking like a case study. Like, I know you're working with one employer that might fit that picture of case study as to how an employer's bringing employees into the building, into their workplace.
Mm-hmm. Okay. Well, a lot of employers, especially medical organizations, are checking people's temperatures when they come in every day. So that's one thing an employer can do to try to monitor his workforce and keep them engaged as much as possible right now. But then when someone is coming back to work, it can depend on the kind of work they're coming into and the kind of environment. You know, if they're working in an office with a lot of cubicles, well, there's going to be potential for a lot of exposure there. If they're a truck driver, or if they're working out in the field by themselves, you know, if they're sitting on a backhoe or something by themselves, you know, in the fresh air, well, the concerns are a little bit less in a venue like that than someone coming to a close environment, like maybe in a manufacturing company. In general, I've tried to throw out the guidelines in the slides that I put together today. So as an employer, you can look at those slides and kind of weigh them against your risk level, and balance that with your need to maintain your operations and your staffing level. And then consider antibody testing those guys that come back. Of course, that's something you weigh against the needs of your company. But then I would also be happy to hold myself out to consult with employers with their specific situation as well. Like I did with the member client that we had earlier this week, you know, because like I said, you know, there's a lot of information out there, and I'm trying to just position myself in the gap to ease some concerns or let employers bounce some ideas off of me or ask me some questions. Okay, so I hope that helps.
Doc, I have another question. And if you need to refer me to a previous seminar, I won't be offended.
No problem.
As we begin to return to work, we are trying to save, especially like N95 masks for those in your line of business. So a lot of us are making our mask or maybe using some other versions. How often can we reuse them, and can we wash them and make them reusable? Or, you know, what should be our protocols with PPE? Okay,
good question. So the N95 mask, there are a few around that you might be able to get your hands on, and then there's some that have been designated for construction, and they've been repurposed for medical use. So I think there are some resources where if you need that kind of PPE, you can get it. And then there's the standard surgical mask. I don't think those are recommended for the general public. But then there's the homemade mask that we're seeing a lot of, and then bandanas and whatnot. And so here in San Antonio now, we're supposed to be using those masks when we're in a public place. There's been some recent guidelines to come out that hospitals are following, where folks can wear their personal homemade mask, but when they're in the healthcare setting, like in front of patients, then they can still wear their homemade mask, but then they put on a hospital or a surgical mask over that. Okay, so those are disposable and they can't be reused. They need to be discarded because, you know, moisture gets in them and then they're not going to be as protective. Then with your homemade mask, you should probably have a few of those that you can change out and launder yourself. So just have a few of those on hand, and then just launder them and use them that way. And then the other part of PPE I'm going to say is just frequent hand sanitizer. That's not something that you put on, but it's something that you do use on your hands, because we know that the way that it's spread is through the droplets in the air, and it's also spread by the things we touch, because those droplets land on the surfaces and they can stay there for a 24-hour period or so. So then the other thing about the mask is the mask is not so much that individuals are wearing out in public to protect them, but it's to protect others around them in case you have the disease and you're spreading it. So the mask that you're wearing is catching the little water droplets that are coming from you when you're talking or sneezing or coughing, and it's preventing that kind of cloud of droplets that happens when you sneeze or cough. That is going to linger there when you move on, like when you're walking down the aisle in the grocery store.
Great, thank you.
So there were some questions that I'm seeing here. Anybody want to mute their microphone and ask a question? If not, I'll go to some questions here online.
Doc, does the term herd immunity, is that exactly what it is? Is that the actual describing large groups of people become immune?
Okay, well, let me just mention what herd immunity is real quick. The easy way to understand that is that there's so many people already immune to it out there in the public or in the herd that you're not going to catch it from them, okay? Because they're already immune, okay? So that's, and you're not gonna spread it to someone that's going to spread it to someone else that's going to spread it to someone else, because that chain of transmission is going to stop with this person right here and this person, because these people are already immune. They're not going to catch the disease and spread it to someone else. And so that's what's happening right now with COVID. And when we have a community outbreak, that's what's happening. This person is spreading it to these people, and these people are spreading it to those people, and it just keeps going generation by generation by generation like that. Okay.
Thank you.
I think we've got a long way to go before we get to herd immunity. But there again, that's where the public health officials and epidemiologists are going to be relying pretty heavily on antibody testing to see what our herd immunity is. So antibody testing is probably going to be around for a while. Okay. And so are there any other questions there? So there was a question about natural immunity and how long, if we'll have that. So natural immunity is what happens when our body sees something like an illness and then starts making antibodies to it. This happens all the time. We're not sure if there's going to be natural immunity to COVID-19. We have to see. We've only known about COVID-19 for 4 or 5 months now. And so it's a brand new disease. We're learning lots and lots about it, not just us, but everybody across the whole world. So natural immunity would be awesome if, in other words, if we get it, if that immunity is going to take care of us year after year. But we know that it doesn't work that way with the flu. That's why every year we have to get another flu shot to protect us from the strain that's coming out that year. Because what the flu virus does is it mutates every year in it's able to create a new disease that way. So we already know that the coronavirus is mutating. There's a handful of mutations out there already. So the epidemiologist and immunologist are on top of that. And so we'll have to see what's going to happen later on this year and next year if this thing comes back. Let's see. The other question was about mutation. We know it's mutating. There was another question about warm weather, and there's been talk about whether the warm weather will slow down the spread of COVID. I don't know if there's been anything out there to show that there has been any slowdown with it yet. So that is yet to be seen, I believe. Okay. All right, so are there any more questions? Now, remember, this is not meant to be Dr. Roger up here giving a lecture, but this is meant to be interactive with employers trying to answer your questions. So if you think this is helpful, let other employer friends know about it, or anybody else you think would benefit from this, and we can do this again. If you have some questions, let us know. You can always send them to us by email or text or through our website.
I have one more question, Doc. If we have a group of employees we want to test, does a physician or licensed professional have to be on site? Or is it possible we could set up a telemedicine conference for the testing, or what are the rules for that?
Okay, good question. So for the PCR test, of course, which is the one that tests for active disease, that obviously has to be ordered by a doctor, a clinician. So there's ways to do that now. There's a drive-through in San Antonio by Freeman. There's Metro Health, and then there's other clinics that are offering that. Direct Med Clinic has that. We're seeing long wait times with Metro Health and LabCorp up to over a week. So we have that capability of doing those kind of tests at Direct Med Clinic. We can use LabCorp if somebody wants to run that through their insurance. We also have a connection with a company where we can get results within 24 to 48 hours. It costs a little extra for that, but we have that for those that want it. And then with antibody, and back to that one, we also have a way to do a virtual visit with a provider to screen someone to see if they really do need a test for COVID without bringing them into a clinic where they would spread it to someone, or they could be exposed to someone that might have it if they themselves don't have it. So the way that would work is through a virtual visit with us, and then we would have them come by in the clinic in their car, and we can have the medical assistant go out and collect the specimen. We've done that a few times. It works pretty well. Keeps everybody safe and gives them peace of mind with getting the test done. And then with the antibody test, that test is done in 15 minutes through a finger stick. So that's something that's usually done in the doctor's office, but it's something that can easily be taken on site to an employer, but it still has to be done under the direction of a doctor who is ultimately responsible for those tests and explaining to the employees what's going on with this test and what does a positive mean and what does a negative mean. So the employers don't want to be answering those questions, so they need to be doing that with a doctor. And the tests are only approved to be done with under the direction of a doctor. But it's something that can be done economically and easily on site, or we're doing those here in the clinic. I have pre-ordered a bunch of those, waiting for them to come in. So we'll have the ability to do a lot of those if we need to.
So if the testing was done on site, does the doctor have to be there, or can that be done for the antibody testing, or does can that be done virtually as well with a tech on site?
Right, good question. So the majority of these are going to be negative. So the doc's not going to have to be there on site. It just has to be done by a trained medical assistant who knows how to collect the blood, work with blood, and be safe that way, and then run the test. So the doc doesn't have to be on site, but if there is a positive, what I'm recommending, the way that we're doing it is that that person will have a virtual visit with a provider to just answer the questions that that person with a positive test is going to have, and figure out if they need to be in isolation and all of those questions. So those are clinical decisions which will have an impact on a company. So that's why a provider needs to be involved, not just on the company, but obviously on that individual and their family and their contacts. And so those are decisions that can't be made lightly. They're very important because they have such a big ripple effect.
Great, thank you.
You bet. Okay. The cost of the test was another question that came up online. The cost of the PCR test is free if you want it that way through LabCorp. But those are the ones that are really delayed. We heard some information that LabCorp is running about 160,000 tests behind. So it takes about 3 or 4 hours to run one test. So they're working around the clock, but you can still see that the demand is high and their backlog is great. So the other test, the other PCR resource we have, it costs about $150. That's for the PCR test to determine if you have active disease. And that's that $150 will get you the 24 to 48 hour turnaround through our other resource here at the clinic. Then for the antibody test, we have a special arrangement for that with our employer clients. But then for anyone else, that test is $50. Okay, hope that answered that question about the testing. All right, well, I hope that this is helpful.
Doc, I see another question just got posted.
Mm-hmm. Okay. Okay, we will go to an employer's office. We have some arrangements that we can make with employers for that. Is that the one you're looking at?
No, sir, there's one more right below it. The Galaxy Tab 53, whoever that is, asked how long do we need to be concerned about the testing?
I'm looking for that question.
Let me look and see. It might have been sent to just me, and it was. It was just sent to me. Sorry about that. It says, how long do we need to be concerned about this testing?
I'm not sure I understand the question completely, but the PCR test is the one that looks for a little piece of the virus and it's testing for active disease. So if you're not sick, then doing that test is going to be a negative. And that's why on the presentation I showed earlier, that's the one where we need 2 negative tests 24 hours apart in order to let someone go back to work. Now, the antibody test is the one that is the finger stick, and it looks not for active disease, in your body, but it looks for antibodies, which are a reaction to the disease that we've had in our body. That's the one that becomes positive 3 days after you become symptomatic with COVID. And it has 2 phases to it. The acute phase, which we call IgM, which rises and then falls, and then the other phase, which is called IgG, which takes a little longer to grow or to rise, but it'll stay positive longer. And that's the one that we look at to determine if someone is immune. So I hope that answered the question about that. If not, if you can give me some clarification on that, I'll try to answer it better. Okay, the test, what is the cost of these tests for those who have no insurance? Okay, so the cost of the antibody test, I don't think insurance is paying for that one because that test is not approved. It's been approved by the FDA to be shipped, but it's not been reviewed by the FDA. The FDA and the CDC are still trying to figure out where they want to place the antibody test in the grand scheme of testing. So that test won't be reimbursed or covered by insurance. So the other test, the PCR test, will be covered by insurance if you have insurance. But then if we do it through LabCorp, it's going to be a week or longer to get your results. If we do it through the other way, then you'd want to pay out of pocket for that. So if you don't have insurance, yeah, it's the $50 for the antibody test, and then for the PCR test, it's the $150, or I don't know how they've set it up to make it free. But that's what they were saying, that nobody should be denied a test. But that being said, you're not going to be able to get a test, a PCR test, if you don't have symptoms. So here's where me as an independent, I sort of break away, and I'm trying to offer what's best for employers or individual patients. So if we have a person that wants to be tested, we will offer these testing opportunities to them. Okay, we're not constrained by being part of a big clinic chain or a hospital system. So let's see. I'd be willing to do more webinars if there's a need for that or a demand for that. I'm also post recording these and then posting them on the website to let anyone that wants this information have access to it. But if an organization wants more tailored information and be able to ask their own more personalized questions for their organization, I'd be happy to make myself available for that as well.
Hey, Doc, I just got a little clarification. The Galaxy Tab 53 is Jason Christensen. He's a contractor, general contractor. And I'm going to read it to you. I think he prefers if I go ahead and read to you. But it says, I was wondering how long we need to continue testing on a regular basis if we feel like it's necessary to start it. I did not know if this was already covered in a previous meeting. So I think he may be talking about like with the antibody test, if he gets everybody tested, how often and how long would
right.
that?
Right, that's a great question. That's a great question. So it kind of depends on what's going on in the community. So what are the numbers looking like in the community? How many new cases a week are happening out there? How fast is it spreading? So the more community spread there is, then the more that you would want to continue doing your antibody testing. And I've recommended to some employers that they test everybody to start with, and then wait 3 days, and then test everybody again. And if there's a lot of community spread going on out there, then if you're doing that, then testing every 3 days, because you've got a workforce that you're really concerned about, then you'd be very proactive in trying to find those people that might be carriers or infected by someone in the community, but they're not showing symptoms right now. Good question.
Dr. Roger, would it be feasible to do it instead of every 3 days, maybe every once a week?
Mm-hmm. Yeah, that's another alternative. And it depends on, that's where we can balance what's going on in the community with the needs of the employer, the availability of the tests themselves, because they're going to be in high demand. They already are. So that's how we can balance that. And so that's another possibility, just doing it once a week. And then, another thing to consider is just testing a certain part of your workforce that might be at greater risk for exposure. So let me just put another disclaimer there. What I'm talking about doing this kind of testing with the antibodies, antibody kits, you're not going to hear from SA Metro Health or from the CDC, because I'm taking that information, I'm taking my clinical training and my relationship with employers to try to help them find options that are going to be suitable for them, for their situation. Not too different than if I have a family practice patient in my office and they've seen 2 or 3 different specialists because they just got a diagnosis of cancer and they're worried and concerned. And the specialists are kind of notorious for sometimes not slowing down to explain things to people. So that's where I'm trying to fill in this gap of explaining things to folks like employers who have concerns. They've got operations they need to maintain and people they need to take care of. And another way that folks can kind of follow up on us and listen to this again, if they've missed something or want to hear something again, we have a YouTube channel that you can subscribe to and get updates to what we're doing. We're always trying to keep people informed and let them know what other options are out there for them. Okay, well, we've gone a little over an hour. Any other questions today? All right, well, again, I hope this was helpful. We'll post this recording on our website and YouTube, and if it's helpful to you, if you got some value out of it, let me know, so we'll do it again. If I can be of any other help to you on a more individual basis, feel free to reach out. Happy to do what I can. So this is Dr. Roger signing off.
Thank you, Doctor.
Thank you. Happy Easter, everybody.
Happy Easter.
Y'all too. Bye-bye.
Indeed.
Bye.
Indeed.
Take care, everyone.